Next session is going to be the AIOS International session, and we have luminaries from all over the globe, advances in cataract surgery. The chairpersons are Dr. Paul Ursel from UK. May I invite you on the stage, please? Dr. Naushad Shroff, I think he's going to be joining in. Dr. Kenneth Fong from Malaysia. Dr. Chi Soon Fek, Dr. Rajendra Prasad, Vaishali is not here, and Dr. Shail Vasavada. So over to you, Shail.
Good afternoon, everybody. Thank you very much for coming. This is the international session, Advances in Cataract Surgery. My name is Paul Ursel. I'm from the UK, and I'm chairing the session. And is my co-chair here? Got Naushad Shroff? Naushad? We've got Naushad here? No. So I introduced the Kenneth Fong and Chin Suk Pei-Sung Chi, who are also joining me. So the first talk is Global Cataract Surgery Results, Eye-Opening Facts. Shurav Daz. Shurav? Hi. Good morning. Good afternoon, rather.
Good afternoon, everybody. At the onset, I would like to thank AIOC for giving me the opportunity to present before you this very interesting cataract global survey that we did on behalf of Alcon, and this probably would act as a North Star for the presentations to come. It will be very relevant parallels that you can drive from it. So last year, we conducted a global cataract survey with 10 different countries all across the world, with different type of patients, one which was diagnosed with cataract and one which was like 50 plus age. The whole idea of this survey was this is better understand from the caregivers and the patients, what do they feel about cataract and the PCL implants. That was a big survey, close to 7,000 patients that we were surveyed about, and India happened to be one of those markets with around 710% of the probabilities. 10% of the patients was a part of this particular survey in the metro and mini metro surveys. And these are some of the very interesting facts that come out. Large people all across the markets, 50% of them actually feel very positive about aging, and India topped it. Close to 80% of them actually felt very positive about aging. When it comes to giving importance to aging, what are the couple of things that patients probably felt was super important? And vision ranked among the top three. Mobility and memory happened to be the others. But in India, vision actually ranked to be the #1 priority when it came to aging. However, there were a couple of misconceptions around cataract surgeries or in terms of eye. And a couple of them, 50% of them actually didn't know about that. Cataract is a pain-free procedure. Like, for example, bandage is worn after cataract surgery. You don't need bandage after that. Large amount of this was something that came out was that 50% actually never knew that you can choose a lens before the cataract surgery, and and so on and so forth. 6 out of 10 patients all across the world, they probably feel that considered a lens option prior to surgery. I was so happy to see, India being one of them. 90% of them actually were consulted and knew that there's a lens option that is probably existing, and surprised in Italy is the lowest among them. This is something that I want to share with you. Of course, when it comes to credibility in terms of getting more information about cataracts and eye care, of course, #1 is, of course, the eye care professional. But what's super important is right next to it was patients and caregivers are seeking for information on the websites. And that was a large portion of it, and which means, if you've not done your website for a long period of time, if it's lying stale out there, it's time that you ramp up and give a new shape to this particular website, because that could be an important piece of information with either the patient or the caregiver is going out for information. Most of them, of course, feel that cataract surgery is an expensive procedure. In India, no surprises. Indians also felt that it was a surprising procedure. But however, when it comes to willingness to invest into a cataract procedure, into eye care procedure, cataract surgery was one of the tops, and then was the brain stimulating and dental implants and so on and so forth. When it came to India, very specific thing, this is something very interesting that, the perception of cost as against, what they probably thought was the word cataract procedure was much, much lower. And the amount of payment, amount of willingness that patients were ready to pay for a cataract surgery procedure from a metro and a mini metro town ranged from 60,000 rupees to as high as 1 lakh rupees, and they were willing to pay for that particular time. Here's when the rubber meets the road, and thinking about what really is when it comes to premium IOLs or the PCLs, and we're going to largely discuss about this in the sessions today, and this is what patients feel. I remember in the earlier part of the presentation I shared about that, how patients feel positive about aging in these days. Largely, with PCLs, they feel much more positive about aging, and it could be here you would see an 8% up when it comes to they feeling positive about aging. And that's a big number. 8% is additional is a big number because, mind you, they don't have any comparison as compared to what they were comparing. They don't have an idea of a monofocal lens versus them. But right away, they feel that this is a game changer for their life. Large part of it, 71% of it, 3 out of 4 patients before surgery, they were willing to pay for a procedure which eliminates the need for glasses. And this is an interesting survey. We asked them that how much would you want to pay for a procedure if there was a cataract procedure wherein you would, your dependency on glasses would reduce, and they gave an X number. And when we actually revealed the figure out, what really came out was very interesting that they felt that they should be paying much more higher. And this was all across. And even in India, when we conducted this survey, it was 92% of them felt largely the same amount of it. This is something that we learned from this, that when it comes to doing activities, we thought they would do all those fashionable activities, playing golf, and these are the things that they would look forward after cataract surgery and when their spectacle dependency is reduced. Strangely, they felt that simple activities like reading, watching television, and at most driving are the things that they would really enjoy when it comes to getting reduced when their dependency on glasses are reduced. Majority of them also felt, and of the 77%, that the quality of life improved after a PCL, a presbyopic correcting, a multifocal lens implant, largely. Strangely, most of them, when we surveyed about this, most of them already were existing spectacle wearers. And that's why this is one of my last slides, which says that, when it comes to the reliance of glasses, 54% of them felt that they actually feel old when they wear glasses, and 50% of them largely felt that they actually feel at least 10 years younger when they had this elimination of glasses. So in a nutshell, if I were to summarize, and these are a couple of interesting take-home messages from the survey that we conducted, there is, of course, a growing awareness of healthy aging in cataract surgery, and I'm not surprised to make this assumption and this recommendation. This is a post-COVID effect, and everybody is super aware of this. Patients are highly motivated to reduce their dependency on glasses, and more so, there is a willingness by the caregivers and the patients to invest in products and procedures for a sustained quality of lifestyle. So that's we concluded. Thanks for your time. Thank you very much.
What is the cohort of patients that the cohort of population that you survey?
So this was against 10 different metros and many metro towns, and we had around 752 patients that we had surveyed.
But that's all good patients, economically well-off patients, or did it have a range of patients?
We had a range of patients. We had a range of patients that we had surveyed, and it was a very credible market research agency that was there. But it was a range of patients, yeah, from different strata of life, if that's what you were asking, yeah.
Yeah, that's what I'm asking. And they were positive about having to get rid of glasses for distance and near both.
That's correct, sir.
But how many, we are facing this problem. You've just heard the Supreme Court judgment saying that they'll pay only CGHS rates for cataract surgery. So how are we going to introduce these lenses and all and continue with these lenses in this country?
Yeah, so that's the discussion that
that's another discussion.
Yeah,
but I'm just saying that many people's wishes might not come true, because although they might wish it, but the clamping down on these lenses all over the world, in fact,
that's true.
is and non-reimbursement of these lenses is causing a problem to all of us.
So right, I think together we should really think about this.
But
and
I think
find out a
what,
solution.
what I found starking in that survey was that 93% patients said that they wanted to read
Yes.
without glasses
Strange,
after
yeah.
cataract surgery and not distance. Whereas we as ophthalmologists are mainly focused on 6/6 for distance.
True.
Whereas that is not probably the most important thing for
Very
them.
surprisingly, yeah, that's true.
So I think we should have investigated in terms of like the patient wants to get completely free of glasses. So that should be the main question. Because the question which you have rose was whether patient wants a clear distance vision, whether he wants the near vision. So see, a lot of people will come out like they want just the reading vision, not the distance vision. But I think the idea is like the patient to get free from the glasses. How many patients they look for this?
So we didn't particularly survey about this, and of course, we cannot really promise any companies that it will be 100% reduction of glasses. But largely, we say that 95% of their daily activities they will be without glasses, and that was the survey part of the question. That 95% of activities would need glasses, and they're happy enough for that. Right.
Yeah, very surprisingly, because a very high number of the people, like almost 90 to 91% of the people, have opted for this.
Right.
And because we will have to, because this is the metro cities, I think patient may ask for this. But if you go to the rural area,
right.
I don't think this because
Yeah.
how many of the
So
rural
there
people
were
included
there
in
were
your study?
none from the tier 3 towns. This was tier 1 and tier 2 for India. None from the survey doesn't, of course, in all honesty, doesn't have tier 3 towns, but tier 1 and this are comprised of tier 1 and tier 2 towns. Yeah.
Because if you ask these rural people, many a times they say,
Right.
I don't need to read. I just want my clear distance vision.
True,
Because
yeah.
out of 100, I was 70, 80 people will say that I don't even read. So why I need the reading vision? Just give me the clear distance vision, and that's it.
Right. So the basic thing I wanted to leave with is that today, with this presentation, with this survey coming up, which is an unbranded survey, nobody knew that this was going to be, is that, today as practitioners, should not be reluctant offering them, thinking that, if you quote them ₹1,00,000 and above, that they would be taken aback. And that's the message that we wanted to leave, that it's not so. There are patients who do not know about this, that there is a service that is available, and if you were to engage into a discussion, a consultation, they might be really keen and interested in opting for this service. So that's what we could take out
So
from
that's
this.
why the counseling is very important.
Absolutely.
Because
Bang on,
right,
yeah.
thank you.
Thank you very much.
Thank you so much for that interesting survey. And our next speaker is Professor Soon Fik. She'll be discussing to us, we've all heard her several times, so I think we all learn something new from her presentation every time.
So thank you very much. Good afternoon to everyone. I'll be talking about battling the Somring's ring. And I think today we're seeing more and more subluxated IOLs in our practice, whether it's in the bag or out of the bag, but very often we are left having to deal with a Somring ring. Like in this case here, it's calcified. You can see the calcium particles do not go into the retractor. So here I'm hoping to cut the IOL at the same time, explant the Somring ring. This half is successful, and we'll see what happens to the other half. So I'm holding the bag together with the IOL half, and it goes quite nicely, except some parts dropping in. So I managed to grab the capsular bag and retrieve the rest of the ring, and you can see it's quite a big ring here. So how can we do this, right? So I managed to use the common forceps, but I still drop some bits, all right? And sometimes we are dropping calcium particles, and that's really bad for the retina because they can be found over the macula. So in this case here, it looked so big and white, but it was really quite soft, and they come in all sorts of consistencies, and it was literally aspiratable, even with the retractor. So we have no problem with cases like this, but sometimes they are really quite calcified and hard, all right? Perhaps not as hard as the first case that we saw, and these do not come out easily, all right? And we have to actually take out the phaco, and you can do it with the sleeve infusion or like this here, just without the sleeve, all right, with the infusion coming from the AC maintainer. But this is far more efficient, but your nurse would have to set all this up. So the technique I'd like to share with you today that will be very useful for not just anterior, but also posterior segment surgeons who often have to deal with this problem is stop struggling with the Somring ring. We know we have to remove it, otherwise the patient will see this big floater in the eye that may not resolve completely. So my technique of dealing with this is to use something that you already have in your operating table. It's an IOL cartridge, and we use this as a conduit. And very often the Somring ring does not come out because we have a slit-like incision And so we have a misfit in the shape of the soldering ring and the incision. And we can use the infusion pressure, which is foot controlled, to allow the pressure to push the soldering ring out of the eye. So let's have a look at the case here. So it looks like soft soldering ring, easy to deal with. So I thought, well, let's get the IOL out. But you look, it unsheathed the soldering ring. The bag came out without the content, and here I am without an infusion, all right? And I was just able to push all this material out without dropping anything. But you need to really ensure you have adequate vitrectomy to do this safely. But better than doing that would be to have an infusion. So we have an IOL here that we are cutting, all right? And as we cut the IOL and remove the IOL, it came out not together, but you can see it left the soldering ring there, and you can see it fragments, so you can't really grasp it. So how do we get rid of this? So we need to close that pupil so that with the infusion, it does not push things behind. And here's just an IOL cartridge, which you direct towards where your soldering ring is, and you can actually nudge it along so that it fits into the shape of your cartridge, and then it's cleanly out, all right? So you don't have to drop any pieces to the back of the eye. Let's have a look at this last case here. So here we have a closed soldering ring, still within the capsular bag, and we're trying to deal with it with a vitrectomy since we already have that out. No, it's not coming. You grasp it, no, it doesn't come out either, it fragments. So you just take out your IOL cartridge, which you already have there because you're going to explant the single piece lens, and you can just push it along to get it in, and you infuse fluid once you've got it into the cartridge. So after this, you can then change your IOL. So in summary, it's very important for these cases when you want to deal with the soldering ring, first to ensure you have adequate vitrectomy, and then you use an IOL cartridge to keep the slit-like corneal incision rounded to enable the infusion pressure to hydro-express the entire soldering ring with ease and in a controlled manner. In this way, you don't drop any pieces to the back of the eye. And these, this cartridge, regardless of the IOL that you're going to implant, is something that's widely available. It's already on operating table because you're going to exchange the IOL to implant a 3-piece IOL. Thank you very much for your attention.
And thank you so much for highlighting the importance, first of all, of needing to remove the soldering rings. Quite often, when you have a particularly in a dead bag syndrome, if the IOL has just gone behind, you pull it out, and when you pull out the capsule, nothing comes out, and you feel there is no soldering rings. But when you actually stretch the iris and look for it, there may be huge soldering rings remaining. So I think, first of all, the take-home message, it's very important to remove the soldering rings, look for it and remove it. And I think an excellent technique. And what ma'am correctly showed, that it's sometimes they just break so easily that very often we have to actually, we typically just enlarge the incision a little bit and just try and visco express it rather than removing it out. But
And
this cartridge trick is superb.
Quite often, because these soldering rings are at the equator, and taking out them from the equator becomes so difficult. Because you have shown the cases where the soldering ring was already coming into the NTA chamber, and then you had removed the. What do you do, like if it is stuck in the equator, and how to take out them, or whether we need to take out them or leave it?
I usually try to remove them, especially if they are the axis where you're going to implant the haptics. Yeah, but otherwise, sometimes if they're not big soldering rings, I might leave them. But once they're bulky, you should remove them. Otherwise, they will start to rub against the iris and cause trouble.
But quite often they are stuck to the capsule.
Yeah, so I will just yank the whole capsule, and I may cut with the vitrector if I need to.
So you use bimanual irrigation aspiration technique to dislodge them from the capsular bag.
So I use a grasper for either the capsule or for the IOL, and grasp the capsule of the soldering ring and then gradually pull it.
Right, thank you.
Thank you.
Next speaker is Dr. Kenneth Mogg, speaking on artisan retropupillary IOL implantation after aphakia.
Thank you very much.
10-year safety and efficacy results.
Thank you very much for the kind invite. I think it's quite an important topic to cover in 8 minutes, and there was a whole 75-minute instruction course on this yesterday. So really, I'm just going to quickly run through the IOL options for aphakia, the iris fixated, my surgical technique, the efficacy data, and the pros and cons of this particular IOL in comparison with the other types of aphakic IOL choices. So the IOL options that you have when you have a patient with no capsule support, I think has been well covered by many other courses, but in summary, you have the ACIL, sutured scleral fixated IOL, the scleral fixated sutureless IOLs, of which there are many, 4-point sutured AIOS IOL with a Gore-Tex suture. We also have the Artisan iris fixated. Initially it was anterior, now it's more popular to be implanted retropupillary and also iris sutured. So when you're doing such cases, you have to consider in your practice what techniques you are comfortable with, consider the learning curve of each particular technique, and what is possible in your actual OT setting. Can you actually get the specific lenses that you want? For example, if you want to do a Yamani technique, can you get the specific IOL with the PDF haptics? You also have to consider whether you can get Gore-Tex or Prolene sutures. If you do the Yamani technique, you need a 27-gauge thin wall needle, low temperature cautery. For the iris fixated lenses, you need the specific forceps and also have availability of those lenses. This lens has been around for many years, and in 1998 it was rebranded as the Aphakia 205Y model with the posterior vaulting feature. So it is widely available worldwide. The A constant, if you are using it retropupillary, is 116.9. It's an overall diameter of 8.5 millimeters with a huge range of diopters, and they've just launched a low myop and a minus myop aphakic lenses as well. They even have a pediatric aphakia range. What are the indications? It's very similar to any of the other indications for the scleral fixated IOLs. Complicated cataract surgery at capsule rupture, eyes without any capsule support after trauma in combination with corneal transplantation, and in many of my patients they have Marfan syndrome or dislocated lenses from the very beginning from congenital diseases. You can actually position these IOLs in any position. They don't actually have to be horizontally because you can grow them. This is important because in some eyes with trauma, their availability of iris tissue may be limited, so you can actually adjust it to the amount of iris tissue that's available. It's often a common question is that when you fixate these IOLs in the iris, whether or not the pupil can be adequately dilated. And it's important to note that the iris is actually fixated to the non-muscular layer of the pupil, and you can actually get a full dilation of the pupil without affecting the examination of the peripheral fundus. So here you can see a patient with an iris fixated IOL or a well-dilated pupil. How I do it is I often combine it with a 3-port pars plana vitrectomy because these patients often have the lenses already dislocated into the posterior pole. I use a 5.5 superior or corneal or scleral insertion, 2 paracenteses at 3 and 9 o'clock. Always remember when you're taking the IOL out from the cartridge, you have to turn it upside down before you insert it into the anterior chamber, rotate it, I grasp it with the IOL forceps and I push it down, 1 haptic behind the iris, and I enclavate it with a round cannula. I do not use the needle that they provide because that's more designed for anterior fixation. I repeat with the other end, suture the wound and remove the viscoelastic, and very often I do not do a PI or constrict the pupil. So in the interest of time, I'll just show you a short video. This is a patient with previous blunt trauma to the eye. I've already removed the lens from the posterior pole. I've already done the vitrectomy. I'm in the process of injecting viscoelastic. So here I put in the IOL with the Artisan forceps. The IOL is upside down, so that's very important to note, but you can actually see it vaulting anteriorly. All the time, as you must imagine, you have to control the infusion pressure. With the lens, with the wound open like this, I do not switch on the infusion pressure because everything will just gush out. I put a bit of hydroxymethyl cellulose to improve the view. And you can see the view is much better. You can use any sort of spatula you want to position the lens in the correct position. The paracenteses have been made here at 3 and 9 o'clock, and it's well marked by the bit of blood at the periphery. So the next step is really to grasp the IOL with the forceps, ensure there's adequate viscoelastic in the anterior chamber, obviously protect the corneal endothelium. And you can see here, I insert the 27-gauge round cannula through the paracentesis, and then I put the haptic behind the pupil, and then I just pull up and push down at the same time, and it literally takes half a second. And then we will repeat the same on the other side. So in total, this is a very quick and elegant technique with a very low learning curve that almost all surgeons can manage it. We run wet labs around the world. We have artificial eyes that can simulate this retropupillary implantation, and many doctors manage to do it the first time they try it out. So I repeat the same on the other side. So you can see here. You can insert the round cannula through the other paracentesis, grasp the IOL with the artisan forceps, enter the iris eye, and just push up on the iris, and then you get perfect enclavation. So you can see that after it's enclavated, I inject the infusion, you can suture the wound, and then the pupil is nice and round, and remove the trocars. So this is a picture 1 week post-op, a nice round pupil, very subtle enclavation of the iris at the tissue. And the tips are that you should avoid hypotony, good field of viscoelastic. I often do not need to myose the pupil because too small a pupil size will make it hard to push the IOL behind the iris, and remember to use the correct A constant. Here's a range of the many eyes that I've done over the years. You can see there's a range of conditions. They've had traumatic aphakia, they've had peripheral iridectomy, they've had trauma to the pupil, but all of them have well-centered artisan IOLs with very good visual acuity outcomes. So my personal experience for the last 10 years, I've done about 154 eyes, average follow-up of 5 years, mean post-op visual acuity of 6.9. In terms of the complications, 0.02% will have choroidal effusion or hemorrhage, 0.006% retinal tear. In one patient, which is a very high myope and deep anterior chamber, I was unable to enclavate the intraocular lens, and I had to put an anterior chamber intraocular lens implant. Post-operatively, the endophthalmitis rate was very low. The most common complication was really late haptic dislocation. And then if there's time, I'll show a video of how you can re-enclavate the haptic. High astigmatism in 3 patients, corneal decompensation in 1, glaucoma and cystic macular edema also were very low. This has all been reported worldwide. Follini's group reported 320 eyes over 5 years with similar complication rates. Min Kim in Korea also had 103 eyes with a very similar outcomes, which are very good in terms of follow-up and also visual acuity. In terms of, there was a meta-analysis published comparing scleral fixated versus iris fixated, and they concluded that the implantation of iris fixated IOLs had a more simple learning curve and short compared to scleral fixated IOLs. Interestingly, this paper was meant to promote the use of the Sharioff-Caravale 4-point scleral fixation, and I found this interesting because this table in the paper itself showed that the iris fixated posterior lenses had the lowest complication rates of 2.8% CME, 0.3% vitreous hemorrhage, and 0.7% retinal detachment compared to all the other intraocular lenses. So as we know, conventional IOL fixation techniques have many other complications which I won't go into. There's not enough time. You have the lens-related complications of lens tilt, decentering, suture-related complications such as endophthalmitis and degradation. Refixation and rescue of these IOLs can be invasive, time-consuming, and technically challenging. So I won't show this because my time is up, but you can refer it to online. This is a simple technique of how you can rescue and refixate a partially disenclavated retropupillary iris intraocular lens. So in summary, the retropupillary iris fixated IOLs have a short learning curve and quick surgery, good long-term visual acuity results, low rate of endothelial cell loss. It's obviously not suitable for eyes with no iris tissue, and often you have to combine it with a vitrectomy operation. The surgical technique is easy and fast and has a very good long-term stability and results. Thank you very much.
Any questions?
Can I ask a question?
Yeah, of course.
Kenneth, have you looked at the endothelial cell counts in the 4 quadrants?
4 quadrants?
Yeah, not just central.
No.
Yeah, you'll be surprised that cell count in the periphery is lower than in the center.
Is that because of the manipulation at the time of surgery?
No, I think when the patient moves forward, the whole lens flops forward,
I see, yeah.
and the iris goes against the cornea, and that contributes to what we would call Brown-McLean syndrome. And I've been explanting these IOLs today.
Yeah.
what is the rate of, because the main concern with the artificial IOL retrofixated is the dislocation or falling the lens back into the vitreous. So what percentage of cases you have come across?
Well, I think in our series it's about 0.05 or less than that. So it's quite small, but I think it's very important that you get proper enclavation of the tissue at the time of the thing. And the thing, okay, the one drawback is it's very hard to remove the lens if it's been properly enclavated. So to disenclavate the lens is extremely difficult, and sometimes you have to pull it, and you have some trauma to the iris tissue. But to lose late dislocation is quite not very common.
Got it.
Thanks. Yeah.
Can I ask one question, sir?
Please.
Very nice surgery, sir. I have limited experience. I have used only 10 of these retrofixated IOLs, but one of the patient developed RD. So during discussion, they are telling there should be a prophylactic barrage laser. So do you do regularly for that?
No, I think the main reason they get RD is incomplete vitrectomy. And of course, I mean, I didn't show the video, but at the end of once the lens is implanted, I do a fluid air exchange. I check the peripheral retina to make sure that's all clear. So yeah, it is a bit difficult, I think, but it's similar to if you were doing what any of the other scleral fixated IOLs, you do have to check the peripheral retina.
Thank you very much. Thank you, Dr. Kenneth. And we'll go ahead with the next speaker now. Is Dr. Paul G. Ursel. Dr. Paul is going to talk on dementia and cataract surgery, a growing problem for all of us.
He is from the United Kingdom. He is the president of the UK Ophthalmic Society.
Thank you very much for the introduction. So yeah, my name is Paul Ursel. I'm from London. This just fits in very nicely with the first talk we had. If you looked at what people worried about, they worried about losing their sight, but even more importantly, they worried about losing their memory.
Could you be a little louder?
A bit louder? Is that better? Sorry. What people worry about is not just losing their sight, as we saw in the first talk, but also losing their memory. That was a higher percentage. So what is dementia? It's a loss of memory, thinking, concentration, and language. And this is not the normal part of aging. Just because some of the people in the room, myself included, might not remember things so well, doesn't mean you've got dementia. It's a natural disease. Unfortunately, it's progressive. It doesn't get better. And the way to think about it, it's quite similar to AMD or optic neuropathy. If you've got glaucoma or optic neuropathy, it's due to raised pressure, or you've got macular degeneration. It could be caused by myopia, subretinal neovascular membrane, dry macular degeneration. Lots of different phenotypes lead to the same end process. And that's how you think about dementia. There's two main causes. The one we've all heard about is Alzheimer's, which is the deposition of amyloid, a tau protein in your brain, which destroys the neurons. And the other form is what we remember from when I was a lad at medical school, was called multi-infarct dementia, which is now called vascular dementia, which is a variation on microvascular disease, which affects the brain as a much more stepwise progression. And these two causes account for about 80% of dementia, about half each. Some Alzheimer's, some vascular, and some mixed, because you've got both. The rest is a variation on Alzheimer's, basically, in different parts of the brain. So people can get a thing called posterior cortical atrophy, which is where it affects the visual cortex. So you can look at a target and thinking, what is that? I know it's yellow. I know it's curved. Is it a train? No, it's a banana, because they can't process the information they're seeing. But there's a problem. If you look at the prevalence all around the world, it's largely due to the size of population. And you can see in India, you have as much dementia as you have in the US. And it's not a small problem. It's something you probably all will see in your practices every day. If you look all around India, this data is from a few years ago. There's a few things I want you to look at in this slide. First of all, it's variable. So if you're in the country as opposed to the cities, you've got different prevalences in different types of state. Secondly, if you look at the data of these productions, a lot of them are 20 years old. And thirdly, you can see it's all across India. It's not located in one specific place. So if you take that fact that the data is from a long time ago, is the latest data I could find, which is from the World Dementia Report, which is about 10 years old. But in that report as well, they looked at what's going to happen over the next 15 years, and this is happening. And India, unfortunately, is having an increased incidence of dementia. It's happening in your country. And so you've taken a disease which is now prevalent, and it's getting worse. Why is it getting, and it's a big problem. If you look at the actual cost to society in India, the amount of money it costs to look after people with dementia because they have falls, they need care, it's as high as pulmonary disease, not quite as high as stroke, but it's certainly more important than depression and diabetes because of the impact it has on a global scale to someone's care. So that's kind of what's happening. Why is it happening? This is happening for very good reasons. The life expectancy is increasing. If you look at India compared to the rest of Southeast Asia, it's doing very well. Unfortunately, though, the fertility rate is dropping, and that means, which is quite good for eye surgeons, a large part of the population are over 65, but they're getting more than one disease. They're not just getting cataracts, they're getting dementia as well. Why is it happening and increasing in India? Unfortunately, it's due to the prevalence of cardiovascular disease. So we have a problem here of obesity, diabetes, hypertension, smoking. And those all lead into cardiovascular disease, microvascular disease, and vascular forms of dementia. This has been shown just recently in Nature from India, showing all these different factors are increasing the prevalence of it. A large problem as well is the fact that the family structure is breaking up as people are moving around into the cities, and they don't have the care support network they would have if they were living at home with their family. So what does dementia mean for us as eye surgeons? This is a large, this is the sort of keystone piece of information to take home. This is a big project that was done in the UK, where they looked at people who have been diagnosed with dementia, and they went in to their homes, and they just did an ophthalmic examination, and they looked at 700 people who've been diagnosed. And the thing to look at is a third of them were 618 or worse, 612 or worse binocular, means they couldn't drive in the UK. This was their walking around vision. And all they did was refract them. And half of them had a refractive error. So you could just make half these people see better with just a new pair of glasses, which tells you they're not getting into the optometrist to get their glasses checked. Of that remaining lot, they looked at why they had poor vision. Half of that was cataract. So in people living with dementia, we can fix virtually all of it. 75% is just fixable. Take the cataracts out, fix their glasses. The reason why this happens is because if you think about our pathways for all our visual needs, they rely on you telling the physician what's going on. I can't see very well, I'm getting glare, I can't read. If you don't do that, the system falls over and doesn't work. So if you ask people what's going on, they don't tell anybody it's happening. People put down the visual decline due to the dementia, not their eyes, and people just don't turn up into the system. And getting a diagnosis of dementia is very bad for having cataract surgery. This is a group where they looked at people being diagnosed with dementia, and they asked them, have you had your cataracts taken out? Yeah, 2 years ago, 3 years ago, whatever. And they age matched them with a control group, and they were the same. But then after the diagnosis of dementia, if you look at the bottom line there, the amount of cataract surgery in the dementia group fell off a cliff, whereas the control group still carried on having their cataracts. So being diagnosed with dementia means you don't get your cataract done. But unfortunately, cataract surgery can help dementia. Hearing aids is a big problem, and because it leads to social isolation, but also so does visual isolation. And this has now been shown from big retrospective analysis in the States, where they looked at about 60,000, 70,000 people. If they had their cataracts taken out, their chance of developing dementia dropped off. So they didn't get dementia. So what do you do? It's exactly the same discussion as have anybody else. Do the benefits outweigh the risks? Do you think the reduction in vision is due to the cataract? Is it likely to get worse? Is there a problem with glasses? If you're a +4 hyperope and you can't wear your glasses, you're functionally blind, simply because you're not +4. So that may well be a very good indication for surgery. Now, when we all see people with cataracts, we say, you know, you're not that bad at the moment. Come back when there's a problem, because you know that will be fine. The trouble is, if you do that and their cognition is getting worse, they won't come back when there's a problem. So what I'm saying to you is, if anybody gets into your clinic and you don't think there's much of a problem, the expression we have in London is fix the roof while the sun is shining. Take their cataracts out when you see them, rather than waiting for them to get worse. Practically, what do we do? Well, one of the problems is, particularly if they've got Parkinsonian-associated disease, is they can't keep their eyes open, they shut their eyes and squeeze and bell. So take the cataracts early before there's a problem. It's an easier procedure. I was taught at medical school that you shouldn't do a general anesthetic in people with cataract surgery, because the general anesthetic will make them worse, and that will balance out the improvements of their vision. That's not true. That data came from people having hip replacements and fractured neck of femurs and heart surgery, which was an hour-and-a-half operation with a lot of blood loss and a lot of recovery. For a little 5-minute cataract operation, that's been shown not to be the case. So you can safely give them a general anesthetic and it won't be a problem. And so it's a really good idea. Quick GA, do both eyes, done. If they're really bad and they're bedbound, probably not the case that it'll help them. A lot of the reasons why they don't get surgery is the carers are worried. So have a meeting with all the carers and saying, what's going on? How can we help? You don't have to worry about padding them after surgery. We can give them Depo injections. You don't need to give them drops. And that will often help the carers come to terms and be happy with them having their surgery. Now, we all make everybody emmetropic unless we're getting multifocal lenses. Now, multifocal lens in dementia is a whole other topic. I can talk to you about that for hours. But we make people emmetropic. But if their lives are they're housebound and all they want to do is eat and maybe read a little bit and they're not going out of the house very much, leave them -1. That means their world is in focus at arm's length, which is what they want to do. And if they can't wear glasses, they're still going to be able to function. And a lot of the time, you can't get them to read and do the assessment, and you do this a lot with illiterate patients, particularly if the people who are looking after the person with dementia haven't known them for very long. So what we do is we record a functional visual assessment. So this is Seema here. Seema can cook, she can wear glasses, and she enjoys telling people stories. You write that down, and then Seema comes back in a year's time. She's not cooking, she's not talking very much. This may be because of the dementia, this may be just she can't see. So today, when you're looking after people in your practice here in India, 1 in 5 people over 80 are living with dementia. That's a big number. A lot of them will not be able to see simply because they haven't got the right glasses on. And if you take their cataracts out, you're going to make them have a better prognosis for their dementia. But they don't get treatment because they don't come to see you. The people who are looking after them don't think it's worthwhile. We don't think it's worthwhile, which is ridiculous. And we put it all down to the dementia rather than their cataract. And we know that cataract surgery will improve their life. Falls, if you look at the dementia literature, is a huge part of the problem. So we don't want them to have falls. And we need to change this. Thank you very much. And if you're coming to London, put the slides back up. If you're coming to London in November, it's the 75th anniversary of Ridley putting the first ever implant in.
Thank you very much. Was this data mostly from India? I find that you have taken the data mostly from the Indian data. So does it include the data from the UK, or what is primarily this data has come from India?
The prevalence and incidence data I have from the UK, but I changed it for India for this talk. So this is what's happening in your territory in India. It is there. It is happening. The data about the surgical treatment is kind of clinical data from our own experience, and the incidence is European data, but I don't think it'll be very much different over here.
So the surgical intervention is more in the UK. The data is from the UK rather than from India, isn't it?
Oh yeah, you do. Your incidence of cataract surgery is higher than ours.
But for dementia, I don't know what is the data. We don't have the data for patients with dementia, the cataract surgery in dementia. I don't think we have it.
We don't have that data, but I don't think the problem will be any different. I think it's a societal problem that people don't present to us for whatever reasons, and then they don't get their surgery because we say come back when you're worse. And that's why it certainly happens in our practice in Europe. I've been trying to change it, and imagine it'll be happening worldwide for the same reasons, not just India, but everywhere.
Thank you very much.
Thank you.
The next talk is by Shail Vesavada on optic capture to the rescue in special situations. Shail
Yes, sir.
is a very prominent surgeon and very skilled surgeon, so let's see what he has to offer.
So we do receive research grant support from Alcon Laboratories. This was a 53-year-old male, right eye grade 2 cataract, nothing very significant. His left eye was already operated few months back, and we had planned a femto cataract with the toric IOL. Everything went off well as per plan, and now we are ready to implant the toric IOL, T3 model in this case. This is all in retrospective. The rexis is perfect, the capsule is perfect. The only thing that was amiss here was that the plunger of the injector was actually overriding on the optic haptic junction. Ideally, the plunger should be at the optic haptic junction. So I'm feeling some resistance while injecting, but I thought I'm okay, I can manage this. I'll be slow while inject in the end. And eventually in the end, I had a shoot. So one learning, first of all, was that if you're in doubt, just pull back and just look what's going wrong and try and do it again, which I did. Now still I'm not feeling very bad because I've filled the eye with a good quality cohesive viscoelastic, and I said yes, there is a jerk, but it's okay, it's a cohesive viscoelastic and nothing will have happened. This has happened to me before. And so I'm still not very concerned, and fortunately the IOL is opened up slowly and I've placed it nicely in the bag. So I have a nice toric IOL now inside the bag covered by the capsulorhexis, but I start seeing a little flap here. And that is the flap, that is the area where the jerk has hit and created a posterior capsule rupture extending up to the equator. So there is unfortunately no way where I can try and go below the IOL and convert this into a posterior capsulorhexis. It is right extending here and up to the fornicis. So now I'm in a little bit of a difficult situation. So I have a single piece IOL in the bag, and that IOL is a toric IOL. And now the treatment options for me to consider, what can I do for this eye? So theoretically, ideally, if there is no good posterior capsule support, a single piece IOL should not be placed in the bag. So I know that. Now the option is to, if I want to try and remove this IOL, if I want to try and explant this IOL and then put a 3-piece IOL, I'm likely to cause a lot of manipulation, maybe disturb the vitreous, which it is not at the moment, and cause more corneal edema, increase the incision size, refractive outcome, so on and so forth. So having had some experience with conventional optic capture, I thought this is something that is worth considering, what is described as the reverse optic capture. So in conventional optic capture, what we have is that the haptics are in the sulcus, and we push the optic below the anterior capsulorhexis so that it stays away. So in the reverse optic capture, what we are trying to do is we are keeping the haptics inside the bag, but we are trying to pop up the optic above the anterior capsulorhexis. So first, before doing that, I want to make sure that I position the IOL appropriately at its toric IOL placement axis, because that's the reason why I'm keeping this IOL in the bag, to correct the astigmatism as well. And then what sorry for that, glitch. So then I'm going below the IOL and trying to push up this optic above the anterior capsulorhexis, so that the optic stays above the anterior capsulorhexis, but the optic haptic junctions and the haptics stay behind the anterior capsulorhexis. And why is this important? Because it is the optic haptic junction and the haptics of a single piece IOL which are large and bulky, and they are the ones which irritate the ciliary body, cause uveitis, hyphema, glaucoma, and therefore it is recommended to never place a single piece IOL in the sulcus. So this is something that we were able to achieve in the end. This ovalization is a sign that this part has been captured, so the optic is above the anterior capsulorhexis. Unlike an conventional optic capture, here you will have a broad ovalization at the bases because the optic haptic junction is very broad. And fortunately, we were able to achieve this optic capture, reverse optic capture, and place the IOL consistently in its position in the bag. And this is how the patient looked several months post-operatively, stable. The IOL obviously has not rotated, cannot rotate because it is locked in its place. And because there was already a pre-existing PCR, PCO also did not develop few months later. There was fortunately only a slight myopic shift. Because the optic is anterior, you may get a myopic shift of about minus 0.25 to minus 0.5. But generally, if you end up slightly myopic, you are unlikely to make the patient unhappy rather than if you end up with hyperopic. So the patient was very, very happy. This was the second case, again very interesting, 62-year-old female, right eye cataract surgery done elsewhere, beautiful surgery, perfectly done rhexis, well-placed single-piece IOL hydrophobic acrylic in the bag, but the patient is extremely bothered with negative dysphotopsia, and the surgeon correctly, recounseled her, reassured her 3 months, 6 months, year down the line. But she's just not ready to accept the negative dysphotopsia. And now she's getting bothered because the other eye vision is getting worse due to cataract. But she's extremely wary that she just does not want negative dysphotopsia in the other eye. So she has come to us that do something first for this better eye, then we'll think what to do with the other eye. But I can't see well with this eye, I need cataract surgery, but definitely this is something that I don't want to tolerate. So she needs cataract surgery, but wary of negative dysphotopsia. So what should be the plan, IOL type and design? And there are several articles on the surgical management of negative dysphotopsia. And the theory is that if you have the optic above the anterior capsulorhexis margin, the chances of negative dysphotopsia are negligible. So conventionally, that would just mean a 3-piece IOL in the sulcus will never get a negative dysphotopsia. There are now special IOL designs, single-piece IOL designs of specific designs which can fix on the capsulorhexis and the optic stays above. And reverse optic capture would probably achieve that with the optic staying above the anterior capsulorhexis. Now the catch here was the patient had significant astigmatism. So in trying to reduce the negative dysphotopsia, we may end up leaving behind astigmatism if we do a 3-piece IOL in the sulcus, and then she'll be unhappy with a poor unaided quality of distance vision. So we reassured her, we counseled her that this is not something very serious. We'll try our best to not have that in the other eye, but you could still have in spite of all our possible efforts. And the plan was once again to do a single-piece toric IOL and do a reverse optic capture. The most important thing of the surgery is to have a good, smallish anterior capsulorhexis, because if the anterior capsulorhexis is large, the optic will not capture. So it is a struggle to do a reverse optic capture of a single piece IOL, and one side was done, the other side came off, and I had multiple maneuvers, multiple times I had to do it, and eventually I could achieve that reverse optic capture. This is, as you can see on OCT, fused margins of the rhexis with the optic above. And this is post-op 6 months, no negative dysphotopsia fortunately, and she's forgotten the negative dysphotopsia in the other eye. Obviously, she will develop PCO early and will need YAG. So I think reverse optic capture of a single piece IOL, although difficult, is possible. So I think it's something that we as surgeons need to keep in our surgical armamentarium for various situations. Of course, the optic is closer to the iris, so these patients need a close monitoring at least in the early post-op, and we'll need more anti-inflammatory and maybe IOP lowering treatments in the early on period. Thank you so much for the patient listening.
Thank you. Shell, what is the physics behind this? I mean,
so, sir, I read it every time when I make this presentation, but I still always forget why the negative dysphotopsia occurs. So
no, why by a capture does it get relieved?
So yeah, so sir, the thing is that the rays passing on through the nasal retina, they sort of, if the nasal retina is too anterior, that's how it occurs, and when it passes through the edge, and therefore the treatments recommended are, YAG capsulotomy on the nasal side of the capsulorhexis margin, or just if the entire 360 degrees of the optic margin covers or is above the capsulorhexis, it will not allow it to refract through it. That's the possible theory.
And this is a known treatment that, or you tried
yes,
it out?
Yes, no sir. Reverse optic capture has been described.
For this condition?
Yes, for negative dysphotopsia, but it was always done with a 3-piece IOL design, not with a single-piece IOL design.
Thank you very much.
I think it is the gap which is left between the IOL edge and the nasal area of the equator of the cataract. It is the gap. So how come doing the reverse optic capture reduces that gap?
So, sir, the optic is now above the capsulorhexis margin, and to be honest, sir, I really don't understand. I've read Dr. Holliday's paper several times. I've heard Dr. Ramamurthy sir's talk regarding this also several times, but I still, it's not something that I can explain very well.
Yeah, I would agree. I would agree. Reverse optic capture is a very good thing for toric lenses, because toric lenses, you don't have the ability to put the haptics at 3 and 6 o'clock, which stops you from getting 3 and 9 o'clock, which is what stops you getting negative dysphotopsia. You've got to move it around to wherever the axis is. So I do reverse optic capture a lot, particularly if the haptics are not at 3 and 9 o'clock. The one surgical pearl is make sure you get rid of all the viscoelastic, because the viscoelastic doesn't come out because it's stuck behind the IOL in the back. Normally we expect it all to come out. So you've got to actually physically go behind the optic to get the viscoelastic out at the end, and you can get caught out with a big distended bag with the viscoelastic shifting the lens forward and causing a refractive error.
Sir, you were going to share your
Dr. Mahmood, yeah.
Basically, what's postulated is the rhexis margin overlapping the square edge of a hydrophobic acrylic lens. And some of the rays of light which come there get reflected back and onto the nasal retina. When it hits the nasal edge, then it gets reflected back to the temporal retina, and that causes positive dysphotopsia. But at the same time, there is also an area of darkness which is there in the nasal retina. And as he said, if the retina is extending forward, that can happen more frequently, and that causes a dark shadow. So the idea is to get rid of this overlap of the rhexis margin onto the square edge. That's why either you YAG that, or sometimes because the pupils don't dilate that well, you cannot visualize that. Then as Shail nicely demonstrated, you can do a reverse optic capture, or you put a sulcoflex lens of about 6.5 millimeters, which has a rounded edge and overlaps that square edge. Other thing is now we have this ND ring, negative dysphotopsia ring, which is essentially just a ring of 6.5 millimeters which can be positioned there, covering that area. I have actually tried all this. Of course, the number of cases are very few, and it gets elevated.
So ideally, we should not have the absolute square edge lenses, because this used to be the concept in the beginning, that have the square edge, so that you reduces the formation of capsular opacity, PCO. But now I think nowadays that the concept has changed, because don't keep absolutely square edge. You have a what you call surface which is modulated, and to reduce the negative dysphotopsia.
It's good to discuss this, but then it's supposed to occur in 17% of the cases initially, but 97% of them disappear over time.
Yeah.
So hardly 1 in 100 cases really bothered by this.
Yeah.
So the progressive opacification of the anterior capsular margin actually takes it away. So the less the exposure of the square edge to the incoming light is what is important. By reducing the distance between the posterior surface of the iris and the anterior surface of the optic, you're essentially reducing the edge exposure to the incoming light. That's how this reverse optic capture works.
Thank you.
The thing is, make sure you leave the haptics at 3 and 9 o'clock. We did that across the board in our facility, and we really reduced the instance of it, and it's much less of a problem with the instance of just because we all forget to do it. But now it's brainstem for me. Put the haptics at 3 and 9 o'clock.
So we'll go ahead with the next talk is given by Dr. Anurag Mishra. Dr. Anurag is going to talk on the charisma of advanced monofocal lenses. Dr. Anurag, please.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, this next segment is basically going to be the advanced technology monofocal IOL, named as Clarion, coming in from the Alcon laboratories. And when we discuss about any IOL, there are several segments of it that we dissect and analyze and discuss. Those elements would be essentially the material. In terms of design, how good it is to the bag, and how effectively does it prevent the incidence of posterior capsular opacification. And since we have moved largely onto the toric platforms and across platforms and across variants, how does it do in terms of the stability inside the bag? So as the picture is quite clearly evident, the Clarion does look more clearer than the Acrosoft over the ages. If you do not take into account the unfortunate incidence of IOL opacification, the thing that actually mars the optical clarity of any IOL with advancing age as it spends time inside the eye are two. One is the glistenings, and the second is the subsurface nano glistenings. To test that, the Clarion IOLs were submerged in a bath of BSS and kept there for 80 days at 91 degrees Celsius, which actually mimicked 10 years of aging of the IOL inside the aqueous bath. And what we found was both SSNGs and the glistenings were significantly lower. They were comparable to any other IOL which did not have glistenings and was there in the market for a substantial period of time. So these are the pictures, electron microscope modified and magnified, to just look at the slits and find out that the SSNGs and the glistening scores were minimal. The PCO, how it behaves inside the capsule, is the PCO rates are already low with the Acrosoft platform. It's also low with the Clarion. Apart from the material, apart from the design, what also scores is the material. This is a square edge design, and the proprietary design that the Clarion has at the edge is it's not very sharp. It's not a 90 degree square edge. It does have a a little bit of convexity on the posterior surface, which fits with the concavity that the posterior capsule leaves behind. And apart from that, there is a stable force haptic, which also takes in the axial compression that happens with the back contracture with a period of time. There's a kink at the optic-haptic junction, which actually takes in that stress. It has a spring action inbuilt. The haptics fold, but the optic does not come forward. So for the toric lovers, this is the news that the fibronectin binding, which Acrosoft platform was so proud of having, the Clarion has it less than the Acrosoft, of course, because the hydrophilicity has increased. The water content has increased from 0.5 to 1.5. But to call any material hydrophilic, the water content has to be well above 5%. So it's still way below that, but the water content has wee bit increased to take care of glistenings, to take care of SSNGs, but the fibronectin binding is still comparable with the Acrosoft. Now, coming to, these are the attributes of the IOL. The testimonials from me, we have already crossed more than 500 Clarion torics. I'm not counting the non-torics into this. And we have implanted all variants of that. 2 of my patients had an unfortunate residual of 0.5, but that was basically due to biometric error, and none of them had residual cylinders. But the question here is, it's not competing with the other brands. What it is competing big time is with its predecessor. Questions are asked, why did we need another material when we were already very happy with the Acrosoft material? So that comparison comes in very handy. Now herein, I'm trying to implant the Acrosoft here. When it comes out of the cartridge, as you can see, it comes out as a rigid cylinder. We just saw Shell's first case, how it shot out. Now, after going into the bag, as I'm trying to still unfold it and settle it inside the bag, the Clarion on the other side is pushed in. It opens up as it goes in. So it doesn't give you that cylinder kind of a fill. And as the Acrosoft is still getting unfolded and getting settled in the bag, the Clarion has already done it. So this is what we gain. This is very slight resistance while it goes out. I'm not saying that the Acrosoft's resistance was too much and not something that we cannot handle, but I'm just saying that this is even better with the Clarion platform. Now, this was one patient, real-time experience, real-life experience. In the left eye, Acrosoft was implanted way back. In the right eye, we have implanted Clarion, and I subjected him to a few evaluations before the eye trace. This is the MTF curve. As you can see, the critical square is right here. This is the internal plane. And at 10 cycles of degree, it's doing pretty well at 0.473, which is pretty good by industry standards. But when you look at the Clarion eye, it's even better. It's almost double. I'm not saying that the difference is this much in every case, but there is a difference, and the MTF curve always does better with the Clarion platform. The same patient with the VSOTF curve, which is actually plotted taking into account both MTF and point spread function, and we know that they are counter-regulatory to one another. As you can see, the peak of the curve, the 100% curve reaches a 0.8, and look at the sharpness at which it rises up. This is the right eye. The left eye is not doing bad, the Acrosoft eye, but still the peak is well below 8.8 and it reaches up to 0.7. Now this difference can be substantial. The depth of focus curve, combined eyes, what is the other question, as it's proposed that the Clarion does give a functional intermediate vision. You can look at the depth of focus curve here, which is all of length and half of width. It's a little tricky to explain that to you, but the depth of focus that is coming from both Acrosoft and Clarion are in the range of 1. So it's not that the Clarion is new to this. The Acrosoft was already providing some amount of intermediate vision. We just were too blind and we were negligent not to look at this. Now I'll end up with this real-time patient testimonial. This was one patient who was very highly myopic. As you can see, the IL power is 18.5, with a very high cylinder requirement as well, T6 in one eye, T7 in the other. I'll just show the discharge summary of the other eye as well. I'm trying to ask the patient to read letters at an intermediate distance of 50 centimeters and look at the patient's response. Do we have sound? Yes. T6 and T8, 16 and 18.
APORFDZ.
This is the N6 line.
81.
I move the chart and look at the phoropter screen. The addition I have given is +1. The patient just read N6 at 35, and he was equally comfortable when we shifted the chart from 35 to 45. So the range is a little more. If you ask me, share the experience with us, I would say that 70% of my patients require an addition of 1 to 1.25 for near, 1 to 1.5 for near. So that makes it a 1 diopters defocus, 1 to 1.25 diopters of defocus. About the rest 30%, a good 10% might need a full 2.25. I've never given a 2.5 add to any of the patients who have received a Clarion implant at least. But from 1.5 to 2.25 is where the rest 25%, 20 to 25% would remain. So it does impart a functional intermediate in quite a good majority of patients. And apart from that, the exceptional material clarity, very good dysfunctional lens index in the postoperative period, MTF and point sprint functions also do pretty well, and the stability is spectacular. Thank you so much for your attention.
I think from your talk, I think, can it substitute for an EDOF lens?
No, sir, not quite, because EDOFs...
Because the +1 correction is normally needed for an EDOF lens also, and what you have shown is that mostly the correction is only +1 for reading in these patients. So have you had a patient in which you have implanted the regular lens in one and the Clarion in the other and seen the difference?
Yes, I have. I've never done a monofocal tri combination, but I have done monofocal and VVT combination in the two eyes. And in fact, one of those patients is an unfortunate one who had a posterior polar cataract in one young patient. The other eye had very bad issues and a T9 requirement, so we could not implant a VVT. We had to switch on to Clarion monofocal toric, and that patient is doing very well. The difference, since you asked, sir, the VVT would give us an N6 at intermediate. The Clarion would never ever give us an N6 at intermediate. But with the near, a +1, as I said, a +1 to 1.5 is what 70% of the patients would require. With a VVT, I would say, 95 to 99% would do very well with a +1 add. They'll never require more than that.
Thank you.
Pleasure. I would agree with that. I mean, I think one of the things we learned from the multi-center trials...
So I can't hear you, sir.
Sorry, one of the things we learned from the multi-center trials looking at EDOFs versus a monofocal lens was the monofocal lens with the Acrosoft and actually got quite a bit of reading vision. And I find that toric Acrosofts are very good for monovision because you get the depth of both eyes almost like an EDOF without having to go down the route of an EDOF.
True. That's the reason why I said we were probably too ignorant to even see that in our patients.
Can we have the questions later? Yes. Sorry. Can we have Dr. Ramamurthy on his talk on presbyopic correction beyond the rings?
Thank you. I'm going to be talking about a relatively new lens in the Indian market. We all are adapting to multifocals, but we are also aware of the significant compliance of blurred vision for both far and near, reduced contrast, night halos, glare, ghost images, monocular diplopia. So though our patients constantly aspire for freedom from glasses, we are not able to give it to them without certain compromises that they have to live with. And not all patients end up being happy. Is there a solution to address this? Very recently, I have started using in the last 6 months or so, the Mini-Well, which is essentially an extended depth of focus lens. The Mini-Well, the expansion is that actually it's called Mini-Well Ready. Mini incision, wavefront engineered leading lens, and it's ready to use because it's preloaded. It's manufactured by SIFI, and the interesting part was it's a totally different optics from what we are used to with the diffractive multifocals. And basically why it's called wavefront engineered is it plays around with the spherical aberration. The spherical aberration is induced in the central pupil and control of the higher order aberration in the periphery of the pupil, because of which it seems to achieve the presbyopia correction. And essentially, we all know that spherical aberration is nothing but the rays of light which are paraxial or close to the central axis being brought to a focus a little behind, and the rays of light which is in the periphery brought to focus in front. So because of the spread of focus is what is utilized in a very scientific manner to create multifocality with this particular lens. The unique distribution of this lens is not, there's no diffractive rings, there's just some zones. Even in these zones, there is no difference in the intraocular lens power per se. The basic power remains the same. The D3 is the area, that's the outside area, which is about 3 millimeters, is monofocal. and the D2 has negative spherical aberration, and the D1 has positive spherical aberration. And essentially, even the amount of spherical aberration in the D1 and D2 would depend upon the basic power of the intraocular lens per se. And these three distinct areas, it has 4 haptics, which gives extreme stability to the lens. Because of this negative and the combination of negative spherical aberration and an aspheric area, there is a spread of focus, and this is supposed to function similar to a multifocal intraocular lens without the compromise as far as the quality is concerned, because there are no diffractive rings, there is no zonal progressive pattern as we used to see in the resume lenses, etc. What about the performance of these lenses? It's supposed to be excellent for distance. Studies have shown that it is excellent for distance and intermediate vision. As you can see, it is in the area logmar 0.00 to 0.1. And when it comes to near vision, it comes to about 0.3 logmar vision. And that again is reasonably good quality vision as far as 33 centimeters is concerned. And most of the normal reading material that we are used to is quite comfortably dealt with this. So what essentially this lens promises is excellent distance and near vision with the intermediate vision, with functional near vision, and without any compromise as far as the quality of vision is concerned. If you compare it with the Symphony, which was once upon a time before the trifocals came in and took over the markets, was one of my favorite lenses. You can see that this lens performs. The orange line essentially corresponds to the mini well. The orange line corresponds to the Symphony, and the blue line corresponds to the mini well. As far as the distance vision is concerned, both are equally good. But when it comes to near vision, the mini well seems to perform somewhat better than the Symphony per se. And if you compare it with the true trifocals, which give excellent near vision, distance, and intermediate, but at the same time, it comes at a cost of loss of contrast sensitivity, you find that again the performance is reasonably matching. As far as the distance vision is concerned, you find that all these, the more commonly used panoptics, the AT LISA, as well as the mini-well seems to function quite well. When it comes to intermediate vision, you find that the mini-well seems to score over these trifocal lenses. When it comes to true near vision, then the trifocals definitely perform a little better, but then only marginally better. Even with the mini-well, you get in the range of about 0.25 logmar visual acuity, which is quite adequate for carrying on most of the normal activities that the patient might want. One other important factor of this lens is, unlike the other trifocal lenses where the light utilization is in the range of about 85 to 88%, here almost 94 or 95% of the light is utilized for formation of the image. And we know that the light which is lost, which is not focused, is essentially responsible for dysphotopsia, for the glare, halos, and other symptoms. And because 95% of the light gets utilized, again the loss in contrast as well as the symptoms of halos and glare is quite negligible, essentially because of the absence of rings in these lenses. Again, it comes in a preloaded platform, and there is because it's a central 2 millimeter, is a clear optic. Even if there is a mild tilt of the lens, or if there is a mild decentration of the lens up to about 0.5 millimeters, there's no compromise as far as the quality of functioning of these lenses. Studies have shown this, and this is essentially the characteristics of these lenses. It's a 10.75 millimeter optic with 4 haptics, and there is a toric version that's also available up to about 4.5 diopters in the lens, correcting about 3 diopters at the lens plane. And it has a unique double square edge pattern, because 2 square edges, something like a platform over here, because of which again the propensity to arrest PCO is significant. And then the IOL material is quite unique in the sense that it's a combination of hydrophobic and hydrophilic. It's not a coating on the surface, but it's a copolymer material which is got zero ionicity, because of which the lens is quite easily introduced even through a 1.8 millimeter incision. And then the incidence of glistenings, etc., is extremely low or absent. And there's a very reliable preloaded system that comes in the system. The time does not permit me to go into the details, but I usually introduce these lenses through 2.2 millimeter incisions. So there's minimal handling of these lenses and seems to work quite well. And what is this well fusion technology? Is it possible to extend this 0.2, 0.3 logma near visual acuity at the distance of about 40 centimeters to 33 centimeters? And yes, there's another lens called the mini-well proxa, which instead of 3 rings has 5 rings. And again, there is a distribution as far as the ring segments are concerned. And both the central ring and the peripheral ring, basically it's a monofocal aspheric, while in the other 3 rings, there is a combination of near and negative and positive spherical aberration. And this gives you a at power commensurate with almost plus 3.5 diopters, giving good vision as far as 30 centimeters is concerned. And what is this? Well fusion technology is to essentially implant a mini-well lens in the first eye and a mini-well proxa in the other eye, so that bilaterally implanted right from without compromise in the quality of vision, the patient seems to have a good, excellent outcome. These are the mini-well proxa and the mini-well toric intraocular lenses being implanted. And you can see that the mini-well, you can hardly see any rings over there, while in the mini-well proxa, which has 5 rings, it's a little more evident. Very quickly, what are our results? We have done 37 eyes so far. And in all these eyes, whether we implanted mini-well proxa, mini-well toric, the visual acuity was 20/32 or better, uncorrected visual acuity for distance, intermediate and near. And when we, 8 of these patients received well fusion, that is mini-well in one eye and mini-well proxa in the other eye. And as you can see here, except for a couple of patients where 20/25 was the near vision, couple of eyes, the rest of the eyes, distance, intermediate and near, were all in the range of 20/20 once the bilateral uncorrected visual acuity. So obviously fairly satisfied patients. So I always used to believe that when you talk about multifocality, it has to come at a cost, at an expense of contrast sensitivity. But this seems to be an interesting concept, and we have implanted it in post-classic eyes, in high myopic eyes, for prelex. And as I mentioned, our experience is limited, just spread over the last six months, 47 eyes only so far. And 3 patients did complain of halos while driving. They are all patients who received mini-well proxa in that particular eye, and which has 5 rings. But I do believe that as we go along, this is a significant addition to our armamentarium as far as our thrust for freedom from glasses is concerned. Thank you so much.
Thank you. Thank you very much. This is, I think this lens is available now. From which company is this? Zydus?
It's basically it's Italian company Sifi, and it's marketed by Zydus here in India.
Okay. The next speaker is Dr. Nilesh Kumar. Efficient surgeries through complex cataract flow.
So, thank you, sir. And I would like to thank AIOS for this opportunity. I'm Dr. Nilesh Kumar. And why I am giving this talk is because we were the first one in the country to have this entire cataract workflow from Zeiss. So these are my financial disclosures. I am a consultant and an R&D from Zeiss. So what are the components that constitute a cataract workflow? The first comes is optical biometer, that is IOL master, either 500 or 700, but preferred is 700. And then the data transferred into Callisto Eye, that is the where you see and you record your videos and you do markerless toric system. Those data and those video feed is injected into your microscope, that is Lumira system, Lumira I, Lumira T, or then 700 or 900, and then the Zeiss Quattro 700, and we are humbled that we were the first commercial installation of Zeiss Quattro 700 in, it was a tier 3 city, but we were fortunate enough to acquire that. So I'll talk about all these components in detail here. So why IOL Master 700, I don't think there is any debate in that this is the gold standard for optical biometry. Most widely installed optical biometer give excellent reference images. So what this does is, apart from giving us the optical biometry, it gives us an excellent reference image with sclera very clear. So that scleral image is matched. The limbal vessels are matched in the Callisto via AI, and that is injected into our Lumra eyepiece. So how it is connected to Callisto is completely, there is no scope of human error. It is directly connected via Forum. Forum is an DICOM-based intercommunication between all the Zeiss machines. So what it does is, once we take an IOL master, optical biometry through IOL master, it injects the data into Callisto through that forum. So completely eliminating use of dependency on any optometrist, as well as reducing any human error. So there might be a human error when they are manually feeding the data. Here it is not going to happen. And then the reference image from the IOL master is matched through the Callisto eye on the patient. Apart from that, Callisto eye also is a digital markerless toric system. So you don't need to worry about your toric placements. It also gives you LRI, it also gives you OCC placements. So complete astigmatism solution is through Callisto eye. And also what it usually does is it records all of your surgeries. So in last 1 year, I have 5 TB of data of my own surgeries. So I just keep going back, any complication that is happening or anything that odd has happened, I just go back and see at the end of the day. That I think optics of Zeiss is world class. There's no doubt about that. Anybody who has used this has been the gold standard for last 7 years, and we are very happy. Now Callisto injects the data into one of the ocular eyepiece, not on the binocular side. It goes on one side. The only problem is this records, but if you are having an external recorder also, then the external camera should not be placed over ADIS, otherwise there is a lot of glare and a lot of poor quality image in that camera. So if you want to have 2 camera systems, this provides, Callisto provides you up to 1080p of video recording. If you want to have 4K video recording, you have to have another camera on another eyepiece. Now coming to the new talk in the town, that is the Quattro 700. Quattro 700 is based on a new pump system. It's neither Venturi nor peristaltic pump. It is something like 4 injections, 2 injections for irrigation and 2 injections for aspiration. So there are like 4 chambers into that pump. So what happens is, if you have, those chambers are hold 32 ml of BSS. So what happens is when 32 ml of BSS is being pushed from one of the chamber, another chamber is vacant where a negative suction of 32 ml has been created. So in real time, it is matching 1 ml of fluid that is going out and 1 ml of fluid that is coming in. So even if there is a minimal amount of leak, it is immediately compensated at that time. That's how there is an absolute rock solid chamber stability. I have operated from around 30 millimeter of mercury in high myopes to 60 millimeters of mercury in my routine cases. There is no difference in chamber stability throughout the machine. So this is how it works. You can see one side when it is injecting, the other side it is aspirating. Both are active. It's not a passive infusion or it's not a passive suction. Both are active, and a pressure sensor is there so that it immediately compensates for whatever leak is happening. So apart from that, there is one excellent benefit. There is something called as power on demand. So we all know at the last piece, we have to use our foot pedal to control delivery in third during emulsification. So what happens in power on demand is only when occlusion is happening, there is a delivery of power. Otherwise, just as soon as the occlusion breaks, the power delivery stops. So there is no, even if you are in a foot pedal 3 position, there is no delivery that is going to happen unless there is full occlusion. So there is no chance that a surge will happen and you won't get a PCR. So PCR rate has rarely, it has gone down drastically since I have started using this machine. So how the entire cataract workflow is, it assesses and educates you You can plan your surgeries via IOL biometer and then via the EQ workplace that is there. Then you treat your patient using the host of machine, that is your Callisto, your microscope, and your Quattro machine. And then you go back and imagine and check whatever wrong has happened. You can just go and recorrect yourself so that next time it doesn't happen. So this is how my OT looks. It has been 1 year since we made a modular OT with a vision that we are not going to have any wires hanging around. But thanks to Zeiss, now everything is wired. There are lots of wire hanging around, but I love working in this environment. I spend around 3 hours in OR daily doing surgeries. And this is my experience in the last 1 year. A single refractive surprise has happened in the last 2,500 cases that I have, since I have started using this cataract suit. Toric accuracy is almost all cases with almost 96% cases I have had a good toric accuracy. Markerless toric system helps a faster OR turnaround time with cataract workflow. And my surgical time has reduced by around 45% with the new Quattro machine. So it's all because of efficient chamber stability that I have less number of phaco rejects now. So thank you for this time.
Thank you very much. But I think many people in this audience won't be able to afford this entire complex, the microscope and the Quattro and the IOL Master, etc. So I think it's an excellent presentation and tells us how to go about it.
So, but we are practicing in a tier 3 city. It was my father's private practice, and we also thought that it is not possible. But I think with the amount of revenue that it starts generating once you have it, I think it's just to take that first step. Once you take that first step, I think, because I joined my father's practice last 1.5 years back. I have exhausted all his saving, but he is very happy that we are now a premium
What
center
machine
in
were
the
you
area.
using earlier for phaco?
Sir, Signature Pro.
Signature Pro, and you find a vast difference between the two?
Yes, sir.
In the surge control?
Yeah, the chamber stability, like the PC doesn't flutter at all in this, and there is no financial interest. I am not being paid to say this, but the PC is completely stable with Quattro 700.
I've used the Quattera, and I've got a video of the side port just leaking fluid straight out.
Because it operates on a flow rate of around 70 to 90. If you lower the flow rate or you lower the IOP, still there is good stability, and they have upgraded it. Last 2 months we got a new hardware upgrade. After that, all those things have drastically come down.
You had a question. We can address it now.
So, sir, I had a question for Shail sir, Anurag sir, as well as Ramamurthy sir. So, I'm a very young surgeon in my practice, and usually I'm not using Alcon lenses. If there is a patient posted for Alcon, I would do the surgery and probably ask my father to inject it, because Alcon lenses, as I've heard from my father, as well as some senior surgeons, that it's famous for sometimes overshooting. So I had the same problem in inserting Hoya lenses as well. When I was doing a wound-assisted IOL implantation, it was kind of overshooting, or I would end up, implanting the lens outside and then again reimplant it. So my question is, if you just increase the main port, and then instead of doing the wound-assisted, if you go inside the wound and then implant it, wouldn't it be better and avoid PCRs in IOL implantation, in Alcon specifically, sir?
I think that's the point that you mentioned is very correct. It's probably not specific to one particular brand of IOL. It is specific to it. There are two, three factors involved. One is the temperature at which the IOL is. So if the IOL is very cold, the hydrophobic IOLs will become very stiff, irrespective of what the brand is. Second is appropriate cartridge and IOL selection. So if the cartridge is too small for that power, that again can cause squeezing of the IOL significantly more. Third is what I showed in my case. If you are not careful, particularly with the shooter injector, if you are not careful enough that the plunger should be at the optic haptic junction and not override on the optic. When it overrides on the optic haptic junction, it gets locked. The IOL gets locked between the cartridge and the plunger, and therefore it doesn't come out well. Fourth, like you correctly said, whenever there is any wound assisted delivery, or any form of, even if you're using a screw injector, there is absolutely no shame in having a slightly larger incision. So safety is always paramount importance. So if you find that with 2.2 incision I'm struggling, make a 2.4 or a 2.5. In my case, that like you saw, the cartridge was actually inside, so it was not even a wound assisted, it was just it was just an oversight that the optic was doing that. So I think these 3-4 things, irrespective of the type of IOL, this will occur even with preloaded shooting injectors, because all of these factors put together can cause this. So I think these 3-4 things, if you keep in mind, the IOL, for example, we make sure that particularly in winters, we bring it only before we actually have to open the IOL. If it's there right from the surgery in the cold winters with cold AC, it will become very stiff.
The only thing I also want to add is that there is not much of induced astigmatism even if you go from 2.2 to 2.4. So this concept of that the desire to go for smaller and smaller incisions is no longer there. Earlier we had this thing, then we had bimanual and other things. So now we've come to a conclusion that induced astigmatism does not increase even if you go to a 2.4 or 2.5 millimeter incision. So go inside the wound and inject it gradually. So, and do not try wound assisted. I don't do any wound assisted injections anymore of the lenses.
So I think very important point by sir, safety is first, rest everything else can come.
And especially while injecting into the anterior chamber, once you start the injection, keep watching it, and say some 1/4 or the half of the lens is gone out of the cartridge. You just try to keep drawing the nozzle of the injector. Just keep drawing slightly, because if your nozzle is at the center, it will definitely hit if you last. But if you draw it a bit, it won't hit the posterior capsule at the opposite side.
I think we come to the end of this session. Thank you very much. I could thank all the speakers and the audience for a very fruitful session. Thank you very much.